stay awake for what we consider to be a really important part of the program. I do want to make a few comments before I begin. It's true that HIV and HCV are both viruses, and it's true that they share some common epidemiologic features, but I think it's important to point out, as we consider the possibility of treatment as prevention for Hep C, to highlight some very important differences between them. And I do want to note that my perspectives are going to be based primarily on the US experience, though obviously I think there are relevancies to other nations in the world. So first of all, it's important to note that unlike HIV, there's a cure for hepatitis C virus. It's a huge difference. And so when we're talking about treatment as prevention, we're not talking about lifelong treatment. We're actually talking about treatment that can be measured in weeks. I think it's also important to note that unfortunately, the advocacy communities for hepatitis C are not as large and powerful and well organized as they are for HIV, which means that by many individual assessments, we have many unmet resource needs when we look at addressing the public health problem of hepatitis C in the United States. And finally, and this is related to the second point, and this is a very important distinction for the US, unlike HIV that does have a large, well-funded categorical program for diagnosing and caring for people with HIV, a program that is funded at billions of dollars, there is no categorical funding for hepatitis C virus in the United States. And so I think you need to keep those issues in mind when we go through and talk about the possibilities of treatment as prevention in Hep C infection and what lessons have we learned in the United States that can help inform how we move forward. Now, everyone, I had to show the treatment cascade, and I don't really care whether you call it a cascade or a continuum. I think the important point is that we want to move successfully from one end to the other. Now, what I want to say here is, although we know in the US, thanks to the good epidemiologic work at CDC, that we have about 1.1 million people in the United States living with HIV, and about 82% of those individuals have been diagnosed. Contrast that with the experience of hepatitis C virus in the United States. And I don't have a continuum to show you, but I can tell you verbally that there are as many as 3 million people living in America with chronic hepatitis C virus, and my colleague John Ward will provide more detail about this, but it might be that as many as 75% of them do not know that they're chronically infected. So when we talk about treatment as prevention for Hep C, obviously a lot of the discussion currently is focused on diagnosis. Now, it's important to point out that, that Hep C, we have an issue with diagnosing Hep C, and you might say, why is that? Again, John, I think will go into a lot more detail about this, but it is important to note, and some of the older folk in the audience will remember a time when we referred clinically to non-A, non-B hepatitis, and it wasn't really until 1989 that the actual virus was described, and we knew what Hep C was, and we had a test for it. So the issue is not that we don't have a test for hepatitis C virus. I'm going to show you a couple of studies from America. The first one took place among adult patients in 4 urban primary health care clinics in the US. And in this particular study, the patients actually did a self-assessment and identified whether they had a risk factor for hepatitis C. And again, Hep C is primarily a blood-borne virus, although it can be transmitted sexually. It's much more often transmitted through blood. So the important point I want to make on this slide is that 36% of these patients acknowledged that they had a risk factor for Hep C and actually presented at the clinic with the questionnaires and shared that information with their providers, yet only 8% of them were tested for hepatitis C. Another example, which is much more recent, comes to us from our colleagues at CDC and takes advantage of a large population-based serosurvey conducted in the United States called NHANES. And this survey gives us a lot of important public health information, including information about the prevalence of hepatitis C virus. This actually shows both Hep B and Hep C, but we'll look at Hep C. And in this particular study, the epidemiologists predicted the prevalence of hepatitis C among a large cohort of adults enrolled. These are people enrolled in healthcare systems in the United States. And so they were able to predict how many of those people should have hepatitis C based on the national serosurvey estimates. Then they were able to look in the electronic medical records and see how many of those persons had actually been tested for hepatitis C. And the bottom line is that, again, we'll just look at Hep C in this context, as many as 43%, nearly half of the predicted infections had not been tested for or diagnosed. So you're starting to get a sense of why last summer the CDC updated its guidelines for testing for hepatitis C, and again, Dr. Ward will go into great detail, but the bottom line here is that CDC said, look, in addition to testing someone who has an obvious risk, whether that's injection drug use currently or in the past, or having received blood or blood products before the time when we were screening for Hep C, the CDC is also saying now that every so-called baby boomer, in other words, every man and woman born between the years of 1945 and 1965 in the United States should be tested at least once in their life for Hep C, whether they can identify a risk factor or not. And this is because, again, we are missing so many infections in the U.S. And how can we even hope? We have curative treatment, but how can we even hope to implement a treatment as prevention strategy if we don't have folks diagnosed? Now let's talk about, again, I don't have a cascade, but I do want to talk about the points on the cascade. Let's talk a little bit about engagement, retention in care. And again, I'll share with you a study published this year in the American Journal of Public Health. This was a telephone survey of nearly 54,000 racial and ethnic minority adults in the United States. And in the interest of time, I'm not going to read the slide. You can see the demographic breakdown. But these individuals were questioned as to whether or not they'd ever been tested for hepatitis C. Bottom line, only 19% of the respondents reported that they'd ever been tested for hepatitis C. Of those tested, a little over 8% reported that they were told that they were infected with Hep C, and less than half of those who were infected with hepatitis C were being followed by a physician. So again, we have problems with, if we had a hepatitis C cascade in front of us, here's an example of some problem of even after diagnosis has been made, folks are not being referred into care. Now, let me get to the point, which was, let's talk about some HIV examples. You heard from Dr. Das earlier in the week about the really important work that's taking place in San Francisco. But even in San Francisco, which is a very well-resourced, very well-organized model of care program, there are individuals who are not, now I'm talking about HIV, there are individuals who are not maintained in HIV care. And here's the point I want to make. This is a recent analysis in JADES. It's still in press, but it's available online. They said that there were only 2 markers that consistently emerged as predictors of poor utilization of care and not achieving viral suppression. And those were unstable housing status and lack of health insurance. Now, what does that tell us about viral hepatitis? Well, this is an example from our colleagues in Australia. who looked at IDUs in Australia, injection drug users who were enrolled in a study of recent HCV infection. And I want to make a couple of points about this slide. But the first point I want to make is that the Australians found among the injection drug users who were treated, first of all, most of them were highly adherent. And that's an important point that we want to make, because I think one of the questions we hear, the young lady from Eastern Europe just brought it up, is the assumption, the misperception that too many healthcare workers have that injection drug users can't be treated, whether it's for HIV or hepatitis C. So the good news is they found very high levels of adherence, but much like the HIV example, when they looked at what predicted lack of adherence or lack of completing treatment, they found this issue, again, housing, and here education. It's actually presented in the converse, what predicted high adherence and what predicted treatment completion. So I think what that means is when we think about hepatitis C and treatment as prevention, and again, I'll say from a U.S. context, though, I think our colleagues internationally have been way ahead of us in the United States in terms of using community health workers, peer health workers, more and more. And I'm not talking about case managers. Those are important players in the healthcare team in the U.S., but we're talking about peers who can actually help people get into care and stay in care. Again, very well established internationally. We're just starting to implement that in the United States. This is an example on the HIV side, and actually this was a study funded by HRSA. But again, I think we need to think about those kinds of approaches when we consider how can we successfully implement treatment as prevention for Hep C. Housing is a huge issue in the United States. There are several studies. It's a very important burgeoning area of operational research. This particular study, published in 2009 in the American Journal of Public Health, was a randomized controlled trial of HIV-infected individuals who were being discharged from a public hospital in Chicago, and they were randomized either through the usual care, which is case planning and some kind of interim housing, or very intensive case management and stable housing. And surprise, surprise, they found that a year later, the people who had the stable housing and the intensive case management were more likely to be alive, more likely to have higher CD4 cell counts, and more likely to have suppressed viral load. So again, may not be exactly comparable to Hep C because we're not talking about lifelong treatment, but I do think the lesson is that if we are treating an individual for hepatitis C virus infection and they're not stably housed, we're probably going to be challenged in terms of treatment outcomes. All right, let's talk about, again, this is perhaps an issue that's much more germane to the United States than it is to Canada or maybe even other places in the world. But the issue that I made earlier, that we do not in the public health system have a categorical program to pay for hepatitis diagnosis and treatment. Very important distinction in the U.S. where we do have the Ryan White Care Act program, and we do have a substantial funding that goes into helping to diagnose HIV infection. And again, these data come from that NHANES study, and the point I wanted to make was the NHANES study does, as I said earlier, does give an estimate of prevalence of hepatitis C among non-institutionalized adults in the United States, and it was in this particular group of data from 2005 to 2008, it was, and it's a sero survey, so they were able to demonstrate that 1.2% of 10,582 subjects had chronic Hep C infection. And the point I want to make is these investigators basically looked for diagnostic codes, looking for comorbidities that would be considered to be problematic in terms of treatment. That's how they determined treatment candidates. It essentially was a paper review. But only 36% of the individuals who were infected that they felt would be treatment candidates reported having health insurance. And that is why when you look at the United States', and I'm going to end with that, our National Action Plan for Viral Hepatitis, you will see that there's a lot of promise that's pinned on the implementation of the Affordable Care Act in the United States. And we definitely see that as an opportunity to improve the diagnosis of hepatitis C, to get more people into care and keep them into care. Now, the issue that came up again, but the young lady from Eastern Europe brought this up about, she brought it up in the context of tuberculosis and HIV, but we're going to hear the same thing when it comes to Hep C. In the United States, the injection drug use is a major part of our epidemic. It's not the only way in which the virus is transmitted, but it is a major way in which it's transmitted. And we are going to hear from healthcare providers that injection drug users, their lives are so chaotic, they're not going to be able to get into treatment, etc. And this data comes right here from British Columbia. For all I know, Jason is in the audience. I don't know what you look like. No, Julia says no, but showing, and granted it was a small sample, but basically trying to address the question about reinfection. And one of the concerns has been, well, why would you treat injection drug users for Hep C? They're just going to go out and get reinfected again. And in this particular study, the point they were able to show, again, a small sample, but they were able to show that there really was a low rate of reinfection. But very important caveat here, and it goes back to something I said on the first day about a holistic approach. The authors emphasized that these drug users who were treated for Hep C had access to comprehensive services that included extensive education, counseling, and the availability of sterile injection equipment. So I think that's a really important point that we have to keep in mind. Now, coming to the home stretch here, the issue of, and I think John and others will probably talk about the several models that have appeared in the literature. This is one from that was published in PLOS One in April of 2012, looking at in Vietnam, looking at the ability, modeling the ability of treatment for HCV to reduce the epidemic. And they did, in fact, in their model demonstrate that, that for every 100 patients started on treatment for Hep C, and they estimated that about 65% would be cured, 94 new infections could be averted. But I also want to make the point that these authors underscored that access to sterile injection equipment and methadone maintenance therapy, which, as they said, is not really highly available currently in Vietnam, that if you were able to expand those services, that you would see an even greater outcome. And going one step further along those lines, another model that was published using data from Australia made the statement that if you do not include access to sterile injection equipment as part of an approach, or the way they said it, if you don't constrain needle and syringe sharing, then in their model, no level of HCV treatment will be able to eliminate the epidemic. So much as we've been hearing for the last 2 days that HIV treatment is prevention, yes, the pills are important, they're life-saving, but that can't be the only definition of treatment. It has to be a broader definition. The same would apply for hepatitis C, that it must be broader, including the fact that some injection drug users will actually continue to inject drugs and do need access to sterile injection equipment and other services. I'm going to, in the interest of time, I'm going to skip that slide. John may talk about it. But I did want to say, just in summary, that when we look at treatment as prevention for hepatitis C, of necessity in the United States, we're focusing a great deal now on the front end of the continuum, because obviously you've got to get people diagnosed, and that doesn't mean that that's the end of it. We do have issues, as I've pointed out, related to the capacity to provide treatment, but I do believe that it's important to remember for the clinicians in the audience that treatment for chronic viral hepatitis is more than just antiviral therapy. There's a lot that can help improve the health of people with chronic viral hepatitis. I learned this lesson from my colleagues at the Department of Veterans Affairs, who care for about 133,000 American veterans with chronic viral hepatitis. And not all of those folks have been treated, but all of them are in care and get information about alcohol reduction, weight reduction, a whole host of activities. So I think we are concentrating right now on the front end. I think it's important to, there's a lot of interest in looking in the US at looking at existing HIV treatments of care, in much the same ways we just heard in the previous session about using existing TB systems to try to leverage ART. In the United States was a lot of discussion, not just obviously for co-infected individuals, it's not even a question, but for persons who are mono-infected with HCV, how can we leverage the extensive infrastructure that's been developed in response to the American HIV/AIDS epidemic? And I think it's clear that we can't just rely on the beleaguered physicians to do this, that we have to pull in everyone from the healthcare team. And in fact, it's been shown very clearly with HIV that often non-physicians are the better individuals to be able to provide testing, because they can focus on that and concentrate on that. And I just wanted to end, this is my last slide, by pointing out that in 2011, my boss, the Assistant Secretary for Health in the United States, Dr. Howard Koh, worked very closely with John Ward and a cast of hundreds across the Department of Health and Human Services to develop the United States' first ever coordinated viral hepatitis action plan. And although in that first permutation of the plan, we don't specifically talk about treatment as prevention, we clearly identify improving testing care and treatment as a strategy not only to improve the health of individuals, but also as a strategy to reduce liver cancer. So let me close by thanking you, and I'm sure that my fellow panelists are going to provide a lot more important information. Thank you.